Yes.
5, 4, 3, 2, 1.
Welcome to Up in Your Business with Kerry McCoy, a production of flagandbanner.com. Through storytelling and conversational interviews, this weekly radio show and podcast offers listeners an insider's view into starting and running a business, the ups and downs of risk-taking, and the commonalities of successful people. Connect with Kerry through her candid, often funny, and always informative weekly blog. There you'll read, learn, and may comment about her life as a 21st century wife, mother, daughter, and entrepreneur. And now it's time for Kerry McCoy to get all up in your business.
Thank you, Son Gray. If right now you're sitting at your computer, you might want to watch the show live on Up in Your Business with Kerry McCoy's Facebook page. I hear from my texts it's actually working. But I do want to mention that sometimes Facebook Live has got problems. And don't worry about that because all of our shows are recorded and a podcast is posted the following week on all listening platforms. You can hear it everywhere. This show began as a calling. After 4 decades of running a small business called flagandbanner.com, a.k.a. Arkansas Flag and Banner, I felt I had something to share. I wanted to create a platform for not just me, but other business owners and successful people to pay forward their experiential knowledge in a conversational way. Originally, my team and I thought it would be this easy, informative, 1 hour a week interview, and boy, were we wrong. As with every new endeavor, it's harder than first thought. Once again, I find myself at the onset of starting and running yet another new business, this podcast, and doing exactly what this show's about, creating a new business, taking risks, and working hard. After interviewing over 100 successful people, almost 160, I've noticed some reoccurring traits among many of my guests. Belief in a higher power, the heart of a teacher, and creativity, because business is creative. Before we start, I want to let you know if you miss any part of today's show or want to hear it again or share it, there's a way, and Gray will tell you how.
Listen to all UIYB past and present interviews by going to Up in Your Business with Kerry McCoy's YouTube channel or subscribe to our podcasts wherever you like to listen by searching Up in Your Business with Kerry McCoy. Starting soon, our podcasts will be offered on the new digital platform of the Arkansas Democrat-Gazette newspaper. And if you would like timely notifications of upcoming guests, go to flagandbanner.com, click Radio Show, and join the email list. Back to you, Kerry.
Thanks again, Gray. Just being a surgeon is quite an accomplishment. Don't we all agree? But my guest today is more than that. Dr. Lowry Barnes is an orthopedic surgeon who is also a businessman and an inventor. This good doctor holds numerous patents on orthopedic devices and hip and knee implants, all developed and designed to improve surgery success and patient wellness. Barnes, of course, is an expert in his field and lectures nationally and internationally on joint replacement surgery. He established the Hip Knee Arkansas Foundation, a nonprofit and research center that further studies patients with arthritis, which I think if you live long enough, everybody gets. He is a prolific writer and on the editorial board of numerous medical journals. In fact, he's been on so many boards that I dare not list them at the risk of boring everybody to death, but it was a paragraph. And it goes without saying he has many awards and accolades. Leaving no stone unturned, Dr. Barnes is known nationally not only for his efficient surgeries, but also for his business creativity. He is an expert on healthcare reform, and to coincide with our recent healthcare system changes, he initiated an innovative payment system for his patients that we'll learn more about today. I'm really curious about that. Of all his many accomplishments, Dr. Lowry Barnes, orthopedic surgeon, inventor, creative businessman, says it's his participation with Operation Walk that he considers one of his most rewarding aspects of his career. It is a pleasure to welcome to the table Dr. Lowry Barnes.
Thank you.
You're welcome. He's been up since 3. I'm over there about to give him some coffee in a minute. What's Operation Walk? You said your participation in Operation Walk has been one of your most rewarding aspects in your career.
Yeah, because it's different than what we do on a daily basis. On a daily basis, we're taking care of patients for insurance companies, and we're dealing with paperwork and kind of doing what we do on a daily basis. Operation Walk is program started by Dr. Larry Dorr, a total joint surgeon in California. And his first trip was to Russia, and he realized that there was something that we could be doing internationally to help patients who don't have the benefit of being able to get hip and knee replacements. And so now there are about 15 chapters around the country that do that, and we go to different countries. Been to India, Peru, Trinidad, and back to Peru, doing operations for patients who otherwise couldn't get it. So we get there on the morning, first morning, we see patients in the office to see who's candidates for surgery. And there may be, unfortunately, 250, 300 people hoping to get surgery. And we can only do about 50 in a 3-day period. We have usually 5 or 6 surgeons from around the country who are working with a team. We take everything with us, not just the anesthesiologist and the people, but all the equipment that's necessary, because most of the countries where we work don't have what we need. So it's very rewarding to have these patients who've not been able to walk very well get joint replacements and get their life back. And the things we learn is these patients, they're tough. Here, we know about our opioid epidemic and the problems that we have with our pain medicines. These patients take Tylenol, and at the time when we first started, they were taking Darvocet, something we don't have anymore, for their postoperative pain. No major narcotics, and they just function. There was a lady I took care of in Peru that had both her hips had essentially auto-fused. So she really couldn't sit very well. She couldn't do much because her hips were so stiff. To go to the bathroom, she had to go to the shower.
Oh.
So we did both her hips at one setting. She took nothing for pain medicine afterwards, and was sitting and walking the next day and going to the bathroom like others go to the bathroom. You don't see those too often in our normal practice in America. You don't see those patients who are just so bad that they can't function that you really can make that kind of impact. We treat patients who have arthritis and get them out of pain and improve function, but it's rare that you change somebody that much.
No wonder it's so rewarding. It's like missionary work.
Exactly.
When you say you take everything, does that mean you have to charter a big plane? You can't go on. Do you go on a commercial plane?
No. So, we go commercially. The people do, and then we send cargo before we go, which is always a challenge getting it through customs.
Oh, I bet.
So,
is it machines or is it just devices?
So sometimes it requires anesthesia machines that are not there, but often it's devices, dressings, drapes, bandages.
So how many? You got 5 or 6 doctors. How many is the whole team?
Usually 35, 40 people.
And you stay how long?
5 days, and there'll be 2 people usually stay a little bit longer to make sure everybody does okay postoperatively.
How do you pick the city, the country you're going to go to?
Each of the chapters around the United States have certain areas where they go. So I've been with a group from Maryland, and Paul Canuja leads that group, and he's now leading it as part of the American Association of Hip and Knee Surgeons. We brought Operation Walk into it, into this big organization a year ago, because Larry's reaching retirement age, et cetera, and we want his dream and what's become so successful to live on.
Do you go every year?
No. Simon Mears, one of our partners here, I met him in India. He was working at Johns Hopkins at the time, and I met him in India, operated with him there. When I moved from private practice, I've been in private practice most of my career, moved to the university a little less than 5 years ago, and I knew that Simon had moved to Dallas and was doing private practice work, and he's truly an academician at heart, great teacher, great researcher, great surgeon. And so I called Simon and said, if you ever get bored doing what you're doing, we've got a spot for you in Arkansas doing academics again. He said, I'm bored. When can I come look? So now we alternate years because he's been a big part of Operation Walk as well.
And he probably speaks another language, which is beneficial.
He doesn't.
He doesn't?
I don't think so.
I thought you said he was Indian or something.
No, I met him in India.
Oh, you met him in India.
Yeah, we were operating together in India as part of an Operation Walk trip.
So when you come back and you have to see Americans, and we all know we're spoiled, me included, how do you make that jump back into caring for these people when you've been like, you don't have it bad. You should see what I've just seen.
Yeah, we feel that about ourselves too. Not just our patients we're taking care of, but we see a whole different side of the world and of civilization that don't have the benefits we have. So it's not just about our patients. So
it's almost like coming back from war. You're like almost in these different cultures, and you come back and you're like, I it's hard to get back into thinking about the materialistic way that we live here,
Right.
the ease of our life.
Yeah, we have been able to do it in the United States as well. We don't do it as much in the United States now. In private practice, we did have a few events here once a year where we could do them. Now, because of the Affordable Health Care Act and more universal coverage, it's harder to do those things because patients are expected to have insurance and coverage, and so it's covered for their plan. So there's really this is charity work, so it's hard to do charity work that way.
And you're saying that there's not that much need for charity work because they've got insurance now?
Correct. For what we do, that's right. That's correct. And here in our state with expanded Medicaid, there's certainly access.
Well, that's nice. So it sounds like when I read about you that you kind of always knew you wanted to be a doctor. You came right out of school, I think, knowing you wanted to be a doctor.
Yeah, it was interesting. So nobody in either side of my family had ever been to college even, but when I was like 5 or 6, 7 years old, I knew I wanted to be a doctor. And then I just kind of got lucky that I was introduced to orthopedics in high school and loved it, and I thought early on that's what I wanted to do. And went to med school here, did residency in Little Rock. The chairman was Carl Nelson at the time. He was a total joint surgeon. I loved what he did. One of my grandmothers had rheumatoid arthritis and was essentially crippled by orthopedic surgeons who didn't know how to take care of patients with the disease process she had. So, she's 85 years old, could work the New York Times crossword puzzle faster than anybody, but couldn't get from her bed to her chair without assistance, and not so much because of her disease, but because of her treatment. My other grandmother had breast cancer and had her hip replaced, and the orthopedic surgeon thought he was operating for arthritic hip. It was actually metastatic breast disease. It was missed. So early on, I saw...
Wait. She went in to have breast surgery and got her hip replaced?
No, she went in to have her hip replaced for arthritis. She'd had breast cancer 20 years earlier, and it was not arthritis. It was actually cancer that had spread to her hip over that long period of time.
Oh.
And so I saw these things. This was years ago, and orthopedics has come so far, so it's been
What year
fun.
is this?
So this was, let's see, probably 1987 when she had her surgery, or her failure. So her surgery was probably in 82 or so. She died. Her failure
In
about
the
5
last
years
30
later.
or 40 years?
We've come a long way. Our imaging technology is so much better now. Our procedures are better.
When you say imaging technology, you mean MRIs?
Certainly MRIs have changed what we do.
Let's talk about what your first operations were like compared to what they're like today.
Sure. So
I can't even imagine.
When I finished residency, so that was in 1991, the average length of stay for hip or knee replacement was 12 days, which was including 1 day preoperatively. Now, 90-something% of our patients go home the next day.
Is that because health insurance won't pay, or is that because it's such an improved operation?
Yeah, it has very little to do with pay. We now realize that we made a bigger deal out of it than it was, and we were scared about protecting patients. Patients are probably safer at home. You're used to the bacteria you have in your own home. You're not used to my bacteria or other people's bacteria, so back in your own environment is the safest place to be. And now we've got great data to show it. So we know that patients who leave the hospital after joint replacement, go to a skilled nursing facility, go to a rehab hospital, they have a higher infection rate and a higher readmission rate and more costly care. And some people have no choice because they don't have the family support.
Correct.
But, we're fortunate in Arkansas that most of our patients can find help. And so we send very few patients to those facilities now.
We're a family-oriented state, I think. Do you happen to know when the very first knee replacements were made? Was it in the 50s?
Yeah, so certainly there were some done in the 50s. It got more popular in mid-60s. Same hips a little bit earlier. And the early results were not great. They were pain-relieving operations, but not so much function improving. So they had tremendous progression over the last 60 years.
Yes. Because I think you used to come out of surgery with a big knee that would never bend again right.
Well, I'm sure they hoped they would bend, but there was a different type of replacement early on the bottom were hinges, so the two pieces were hooked together, very much like what a lot of my patients think when they come to see me, that we're going to chop off the end of the thigh bone, chop off the top of the shin bone, and put two pieces of metal that are connected together, and that's going to be your new knee joint.
What are you going to do?
In reality, it's really a resurfacing now. So on the femur, we make 5 little cuts to trim the bone, and it's capped with a piece of metal, usually chrome cobalt metal. And the shin bone, the tibial side, has a flat cut made of it, taking off a few millimeters of bone with a metal base plate being placed on it with a plastic insert. And then we trim off some of the kneecap and put a plastic button on it. So it's really very little bone resection. It's a resurfacing operation.
Do
really.
you harvest some ligaments to use to rebuild anything?
No, the ligaments are actually substituted for. So the implant itself does that, and so we actually take the ligaments out on the inside part, the anterior cruciate ligament.
You don't need it. What's an ACL? Is that a ligament?
It is. That's the anterior cruciate ligament.
You don't need that. You don't need that one anymore.
Not with a knee replacement. And we actually take out the posterior cruciate ligament as well, which is the one behind it, because the implant can give the stability to the knee that those ligaments do.
And it's amazing that you, like you say, you buttonhole it on. So one side's screwed and the other side's buttonholed? No,
they're actually both cemented into place, but it's a special medical type of cement called polymethyl methacrylate that sets up quickly.
What did you say was buttonholed?
I don't know.
Didn't you say that?
No, you made that up.
I may have. That's very true. All right, this is a great place to take a break. When we come back, we'll continue our conversation with orthopedic surgeon Dr. Lowry Barnes. We'll ask Dr. Barnes more about joint health and the progress his research center is making in the study of arthritis, about what he thinks is the future of medicine, and about the process of getting a patent and what necessitated his inventions. We'll be back after the break.
You're listening to Up in Your Business with Kerry McCoy, a production of flagandbanner.com. Over 40 years ago, with only $400, Kerry founded Arkansas Flag and Banner. During the last 4 decades, the business has grown and changed. Over this time, Kerry's business and leadership knowledge grew. As early as 2004, she began sharing her knowledge in her weekly blog. In 2009, she founded the nonprofit Friends of Dreamland Ballroom, and in 2014, Brave Magazine, a biannual publication. Today, she has branched out into this very radio show and podcast. Each day, you'll hear candid conversations between her and her guests about real-world experiences on a variety of businesses and topics that we hope you'll find interesting, inspiring, and educational. Stay up to date by going to flagandbanner.com and joining our email list. You'll receive our popular Water Cooler Weekly e-blast that notifies you of our upcoming guests, happenings at Dreamland Ballroom, sales at flagandbanner.com, access to Brave magazine articles, and Kerry's current blog post. All that in one weekly email. Telling American-made stories, selling American-made flags. TheFlagandBanner.com. Back to you, Kerry.
Thank you again, Gray. You're listening to Up in Your Business with me, Kerry McCoy. I'm speaking today with Dr. Lowry Barnes, orthopedic surgeon in Little Rock, Arkansas, who is internationally known for his patents and innovative approach to hip and knee replacement surgery. Before the break, we talked a little bit about the history of orthopedics, the evolution, I guess I should say, of orthopedic surgery. And
great name. That's one of the implants I designed, was the Evolution Knee.
Really?
You read something, didn't you?
No.
Okay.
Yeah, yes, I did. Yes, I did. Yeah, I knew that. So, yeah, it is absolutely evolution. And so let's talk about that. How did the idea to reinvent hip and knee devices come about?
Well, we're always trying to make improvements, not just me, orthopedic surgeons and engineers around the country, saying how can we make the knee more like the normal knee, increase function for patients, and have it last longer. So the one you referred to, the evolution, is one that was started by a company called Wright Medical. Now has been sold to Microport, who bought the hip and knee line from them. And there were 5 or 6 of us on the design team who took a previous iteration. It was called a medial pivot knee. So a lot of different designs of knees based upon saving this ligament, saving that ligament, how the knee functions and kinematically, how it bends and where
the injury is.
Yeah, not so much that, because this is we do knee replacements for arthritis, not for injury. So it's really more about restoring the kinematics or stability and how the joint functions. And so this design functions more like a normal knee, in that the inside part of the knee acts different than the outside part of the knee, just like ours does. The stability of our knee comes from the inside, and the outside portion has more laxity to it, and that's where what allows flexion of your knee, but still has stability from the inside part. So we reproduce that in a knee implant. Unfortunately, it's now become very popular in that many other companies have now mimicked that design.
Is it an actual device, or is it a procedure?
It's a device.
And did you have to get a patent? And you got a patent on it. Your group of 5 decided, this is great, let's get a patent on it.
Yeah, so there are a series of patents associated with an implant, as you might imagine, because there are a lot of different changes. So one might be related to a special instrument that allows us to size the thigh bone a certain way. Another might be related to how the plastic locks into the metal. And so each implant can have a number of different patents if what you're developing or designing is different enough than what's been designed before.
I never thought about that. You've got to make the tools. You've got to design tools, because every time you try to do anything in construction or in sewing or in anything, it's about the tools.
Instruments matter.
They really do matter. How many patents did you end up making?
I don't know how many I have. 10 or 12, I guess.
So do you have them as an individual, or do you have them as this team of doctors?
So they're as a team. So they're often, it depends on who's working on what part.
Do you get residuals from it, or does your team get residuals?
Both. So the individual gets it as it is. Like that company has no longer get residuals from that. I bought out my contract years ago. We more recently, my mentor, Dick Scott from Boston, who I did my fellowship with, he and I and one other gentleman who's an engineer who had worked with Dr. Scott in the past, the three of us started a new company. At the time it was called Responsive Orthopedics, and developed a new type of knee and hip, and looking at a prosthesis that was less expensive and served the needs of our population well, because it had all the same modern capabilities. And then Medtronic, one of the large companies in the healthcare world, bought our company a few years ago. So.
But it seemed like the knee and the hip would not be able to use the same procedures.
They don't at all.
Maybe the same instruments. But
not the same instruments, not the same implants, not the same procedure. They're totally different.
How long does it take to develop a procedure like that?
Procedure's still developing. We make minor changes each year of the 50 years. Implants can take, the design process may take a year, but getting approval from the FDA and kind of going through the whole process may take 4 or 5 years.
So this new hip that you invented, the evolution of the knee, what'd you call it? Evolution knee. What did it solve? What did it do for the patient that he couldn't do before, in layman's terms?
It gave him what we think is a more normal feeling knee. So they have stability. One of the challenges you have for knee replacement is that if you go downstairs or do rotatory motion, sometimes your thigh bone can slide on your shin bone. This implant gives you stability, inherent stability, and we think that's important.
So no canes are needed?
No.
What do you think is, of all of those surgeries, which one's your favorite one that you think you've had the best success ratio on?
Whichever one I'm doing at the time.
Good answer. See, I told you he's a businessman. What is the biggest hurdle patients have to overcome after surgery?
Oftentimes it's before surgery, not after surgery. It's deciding it's time.
I agree with that, because people are afraid to do knee surgery.
No doubt. And it's, and unfortunately, we have certain groups of patients who don't get knee replacement at the same rate as others, because we don't know if is it a health literacy issue? Is it a fright issue? Is it an access issue? And those are kind of things, some of the things we're trying to figure out now, how we can make sure that more patients who need knee replacements can get it.
Is it better to put it off for as long as you can, or does that actually hurt the operation when you get ready
Great
to
question.
do it?
If you get too far, you get too many deformities, your leg gets too angled, or you can't get your leg straight for a long period of time, then patients don't do quite as well. But you don't want to do it too early either. Used to, about the time I was training, we were very careful. These operations were for older patients because you didn't know how long they were going to last. When I was in Boston doing my fellowship, my chair, Dr. Clem Sledge, we're seeing a patient in their early 50s or so, and he said, "What do you think?" And I said, "Well, bad. I can't remember if it was a hip or knee." I said, "Bad problem, but they need to be older." He said, "Why would you do that? They're at their prime of their life now. Why would you tell them they have to wait? They can't do the things they want to do now. So why don't you take care of them? If there's problems later, fix them then." And that's where we are in joint replacement now.
How long do they last?
We don't know for sure because everything is a little different. Each model changes, and unfortunately, when you say how long does it last, it matters about a lot of things.
PT?
A lot of that happens in the operating room. How good is the surgeon? How well is it placed? If it's a knee, how well are the ligaments balanced? How well is it cemented into place? How good is the component itself? If it's the plastic that's being used. So there are a lot of things that affect it, and we often say on average 15 to 20 years for both hips and knees. Some last much longer, some last much shorter, and that's a problem. The early failures of joint replacement are a problem. I think that's probably what scares people.
Yeah.
We have a very large revision practice.
So you're saying don't wait. We can always redo it again later because you're at the prime of your life. Why be miserable during the prime of your life?
If you meet all the other criteria, you failed non-operative management, you've done physical therapy, you've tried anti-inflammatory medications, Tylenol, you've gotten your weight to an appropriate level, but you still have end-stage arthritis.
You just answered all my questions.
Good.
What is preventative? Weight level? What were the other ones you said?
Strength is important. So especially for the knee, the muscle in the front of your thigh, the quadriceps.
Should you be doing weight training?
Certainly, weight training is good for everyone because it helps build the bones. It helps prevent osteoporosis. Bones respond to stress. So if you have a load on it, that helps the bone form new bone. But the quadriceps muscle, really just doing leg lifts and bicycling are enough to keep that muscle toned. Many people think just walking is enough, but it's not for that muscle. And we see that after knee replacement. Patients sometimes do their therapy early, then they may come back in 6, 8 months later and say, all of a sudden my knee hurts. And we test them, and their quadriceps strength is half what the other one is.
Because they're walking.
Well, they just hadn't been doing exercises. They kind of got past their pain and the therapy early on, and they got on with their normal life and kind of quit. And so now they're weak. And so then the joint starts taking more of the load. Having muscles that function well across the front of your knee are the dynamic stabilizers of the knee, so it takes stress off the knee.
So go ahead.
So we get the patients get their muscles stronger. We send them, test their strength, show them how much weaker they are, send them to therapy, build up their strength, retest them. Invariably, when they get stronger, their pain gets better.
I think that's true with every ache in your body is go out and do a little exercise. It seems like as I get older, though, I want to do more swimming.
It's great for you.
It doesn't seem to hurt your joints. When I ride a bike, it seems to make my joints hurt.
Yeah, it depends on the problems you have. Bikes are great for hip and knee replacements because they encourage motion, and it's good for arthritis too because you get motion that's not weight bearing. Swimming is the best, especially with the hip because it's great for after hip replacement to have a patient get in the pool. Oftentimes I'll turn to my PAs when we're seeing a patient and say, "Been in a pool or not been in a pool?" Or
it's a game.
Or they say, "I've been swimming." We look at each other knowing they're doing so well because they've been in the pool and they've gotten their motion and they're not tight.
Plus it's chilly, so I think it reduces inflammation as a rule. So you're getting into it's not really an ice bath, but it is chilly.
Yeah, many of the therapeutic pools are warmer, obviously.
Well, that's true. Yeah. So I would think that you have a problem with people doing their PT, physical therapy. It does seem like my son who had ACL replacement because of someone hit it. He was on a bike and a car hit him, and he had to have ACL replacement. And they harvested his hamstring.
Sure. Which
was fascinating for everybody listening. But he He won't do his physical therapy.
Mom, get him going.
I know. But so I think about you. Are you frustrated all the time about that?
No, because most of my patients do their therapy because it's a different type thing. So your son had an injury when he was normal one day and then has a problem and not really into the whole fix.
And he's young.
Yeah.
He doesn't know.
If you've had arthritis for 10 years and affecting your life every day and you get an operation, most patients are pretty determined to do what they're supposed to after surgery to get the benefit from their surgery.
So do vitamins work? Because you see people all the time talking about take vitamins and it'll help.
Not that I know of for arthritis.
You're like the 20th person. They say joint pain, take vitamins to, glycosamine.
Yeah, so no proven benefit for chondroitin glucosamine. There are some animal studies that show some relief, some cartilage changes. Some patients swear by it, and my answer is if you take it and you think it helps you, keep taking it.
That's right.
There's no side effects that I know of.
Okay, good. Any advice for sufferers who might be out there besides diet, exercise? Was there something else? Pain management?
Yeah, over-the-counter pain meds usually, so Tylenol, anti-inflammatory medications. The biggest thing I can tell you is no patient should be taking narcotics for arthritis, and no doctor should be prescribing narcotics for hip or knee arthritis.
That's for sure. It's a great place to take a break. When we come back, we'll continue our conversation with the inventor, businessman, philanthropist, author, orator, and renowned orthopedic surgeon, Dr. Lowry Barnes. And if you have a question for Dr. Barnes, stay tuned. Son Gray will give you the hotline number after the break. I want to remind everyone we're broadcasting live every Wednesday from 6 to 7 p.m. Central Time and on 101.1 The Answer. And up on Your Business with Kerry McCoy's Facebook page if it's working on that day. And that after each show's airing, a podcast is made available on all popular listening sites and YouTube. Phone number when we come back.
FlagandBanner.com is proud to sponsor Up in Your Business with Kerry McCoy. TheFlagandBanner.com is so much more than a flag.
No.
Hey now.
Look, he's got a bigger head than
Do the
you.
number? I got it. Okay. Thank you.
Look, his head's bigger than yours. We can't even find cowboy hats for him.
Not your mother.
Yeah.
You know.
Yeah, my son will not do his exercise.
Go figure.
Yeah, right. 27. Of course, you're not doing it.
He's not 27. He just turned 25.
Yeah, even worse. Yeah.
Yeah.
Where is he?
He's in Mexico City right now. He's in Mexico right now, but he's at Ohio State.
The Ohio State. What do you mean?
The Ohio State. Getting his PhD in horticulture. They're learning how to grow food without water. He specializes in chili peppers.
All right.
You know, I don't know, kids, but he was on his second day of school and on his way to school on his bike. First year at the school. You're listening to Up in Your Business with me, Kerry McCoy. I'm speaking today with Dr. Lowry Barnes, orthopedic surgeon in Little Rock, Arkansas, who is did I say that crazy?
Say it again.
Okay. Who is internationally known for his patents and innovative approach to hip and knee replacement surgery. If you have a question you would like to ask Dr. Barnes, you may call
501-823-0965.
Say it again, son.
The number is 501-823-0965.
Before the break, we talked about, I love talking about the work you do in, what was it called, Operation Walk?
Right.
Operation Walk is kind of a missionary thing where a bunch of doctors get together. It's funny when you get older how you want to help everybody. You notice that?
No doubt.
How long have you been doing Operation Walk?
No, 12 years, something like that.
Oh, long time.
Yeah.
So even when you were in your hard-working career, you were doing it.
I'm still hard working.
You are. I should tell everybody you look like you need a nap. You've been up since 3 in the
Come
morning.
on. But you're right about giving back. I mean, I left private practice about 5 years ago because I wanted to be back in academics and
teaching.
You know, it's the next generation of orthopedic surgeons, the next generation of students. People need to know that it's fun to be a doctor despite all the challenges that may come with being a physician, with paperwork and all the financial challenges that we face. There's nothing like having a patient appreciate what you've done for them and changing their lives. And So I'm glad to be back over there and working on that and building the orthopedic program. And you talk about business. Well, so we've certainly improved the business of orthopedics at UAMS as well. We've grown significantly, and it's fun. We've got a great team.
We're lucky to have UAMS.
Yes, we are.
I think it's really nice that you're paying your wisdom forward.
Well, thanks.
Speaking of the expense of becoming a doctor, it's $200,000 in debt to become a doctor today, right now, which is why people are specializing, because you've got to pay that debt back. But we don't have enough general practicing doctors.
That's a statement. You look at me like you want to answer.
I thought you might say something about that.
Yeah, I'm kidding. So I think that's not why people become specialists. Why most people become specialists. Some may, but most people figure out where their niche is and where they think they can do the most benefit. And I think
right now we are at a crushing $1.5 trillion in student debt. That's unbelievable. And by 2030, we are going to have, in learning about you, all these statistics came up for me to read. By 2030, we will have 50,000 doctor shortage in primary care.
Right. No doubt it is a major challenge.
Is it because it's so expensive to go to school to become a doctor that low-income families cannot do it?
Yeah, I think some of it's that, and some of it is that, unfortunately, doctors don't make as much as they...
Specialists.
And so, well, any doctor, as much as their peers who have put the same number of hours in for that period of med school, residency. You know, you take 9-10 years of your life there where you're making a sacrifice financially to learn your profession. And so I think many people see their peers from college that are doing very well, et cetera, during that period of time. And so then they see their older siblings that have done medicine, others that haven't done medicine. They start looking at the challenges. But certainly the cost of a medical school education is significant.
Did you see where NYU recent announcement that all tuition was going to be free?
Yeah, and they just actually gave some released debt to the to people as well, not just going forward, but in the past, and that's huge. Wouldn't it be nice if this state had that kind of money to have that kind of endowment to pay for the medical education of the students who want to be docs?
I saw the guy, Ken, and his wife, Elaine, who are the co-founders of Home Depot, who were the people that gave the money, and he said he was doing it because he wanted more primary care doctors, and he felt like that might help low-income people who have a desire to be a doctor, to get in the field.
Let's hope it works, and I wish he want to come do the same experiment in Arkansas, and then he could compare a rural state like ours to New York, and who benefits the most from that kind of investment into primary care. We totally believe primary care is so important to the health of our community. You know, for too long we've talked about health care instead of about health, and the primary care physicians are the ones who can most likely improve the health of our state. We are ranked 46 in the country for health, so not where we need to be.
The worst health?
Yeah, 49th for obesity. Only Alabama's worse. So these are areas where we can make marked improvement for our community.
Those are almost educational tasks on how to eat right and how to exercise, though. Almost. I don't want to treat them after they're sick. I want to treat them before they get sick.
Absolutely. And then all the other things for which you may need to be treated, your outcomes are better.
Yes.
We can decrease the risk of diabetes, the incidence of diabetes for secondary to obesity, for type 2 diabetes. If we can see that those patients who have diabetes better manage their diabetes, well, then when you go in for another procedure like your gallbladder, your risk of complications goes down. Mm-hmm. Same with obesity. So we know that these things make a significant difference. And then we have all the social determinants of health care which affect our state.
What do you mean?
Appropriate housing, food. We have too many people in our state who don't have enough food to get proper nourishment, like
healthy
14%.
Food.
Yeah.
Yeah, they're eating cheap food.
Yeah. Transportation so they can get to and from health care providers. Mm-hmm. So we're doing what we can to try to take health and health care to people.
I haven't thought of it like that. I haven't thought about not being able to get to the doctor. Arthritis. You started a hip and knee Arkansas Foundation. It's a nonprofit. It's a research institute. It's really looking at arthritis and the causes of arthritis. What causes arthritis?
Sure. I should point out that Hip Knee Arkansas is actually something I did when I was in private practice. It still exists, but most of our research is done through UAMS now. So we have a very strong orthopedic research program. It has grown significantly in the last 5 years. It's run by Erin Mann, a PhD in biomechanics. She's absolutely an all-star team builder. So we have lots of people working with her. The students work with her, postdoc, PhDs, much like your son. Instead of those kind of projects, they're in our lab working on how do we treat these issues and how do we prevent them. So it's been a lot of fun. And I'll answer your question about arthritis in a second. But at the lab right now, the hip knee lab, we have this incredible equipment so that we can do great gait analysis and motion analysis studies. When I was in private practice, we had a donor give us a significant amount of money so we could establish this. So we have a lab that has force plates so you can look at weight transfer, high-speed cameras to look at how the body moves, and we then do fun things with it. Like right now, we're looking at the golf swing. So we're looking at how does arthritis affect the hip and knee, and now the spine also in golf swing, and how do patients respond after joint replacement. So next week at the Hip Society meeting, my talk is on loads on the hip in the golf swing. We've been telling patients wrong for years how to go back to golf after joint replacement.
What do you mean?
We've always said go back, use your short irons first, then use longer irons, and then get to your driver because you'll put less torque on your hips and on your hip doing that. In reality, the 6-iron and the driver are the same. So it's really about how hard you swing, not about the club length. So it'll be fun to share this because there'll be a lot of golfers in the group.
Well, people can relate to that.
Absolutely.
You get up there and start talking with all that doctor lingo, they're just going to glaze over. But you go, hey, you want to improve your golf swing? They're like, what? What do you say?
Exactly.
So Tiger Woods had back problems.
No doubt about it. And so we're looking at the golf swing after spine fusions as well, which is what he had.
Is there any sport that doesn't hurt a man? I mean, basketball, football, golf.
Certainly they all have their benefits, but they all have the potential risk of injury. And post-injury is when we see arthritis in the knee oftentimes.
So what is arthritis?
Arthritis is when the cartilage starts to wear. So
is everyone's cartilage going to wear out?
Probably if you live long enough, you'll have some arthritis, but not so much you have to be treated by an orthopedic surgeon, and maybe not even by your primary care doc for that. But the prevalence is quite high. And if you have trauma to it, an injury, or if you're obese, it's certainly higher for the lower extremities.
Well, I mean, I'm thin. Why do I have backaches?
Well,
I mean, I don't know.
Backache is a multifactorial thing. So we all have back pain.
But don't you think it's
goes.
Cartilage that comes in the back of your spine? In that?
Well, you have discs there that have some cartilage in them, and they from fiber cartilage, and certainly you can have deterioration there with aging. You really wanted to hear with aging, didn't you?
Yeah, I was just about to say you could leave that word out,
yeah.
didn't you?
but our back sees lots of load, right?
Yes.
So we do lots of things, twisting, turning, bending.
And women carry purses everywhere. So what do you think about steroid shots? Speaking of, I've heard, they will cure any kind of inflammation you have in your body, but I have heard that they, and I don't know, or that they are not particularly good for your bones. Being an orthopedic surgeon, what do you think?
Great question. So steroid shots really don't cure anything. They treat symptoms.
Right.
So I can tell you I've had steroid shots. I've had steroid shots to my back by Dr. Gorey at UAMS, who's absolutely a magician with a needle. And I'd do it again in a heartbeat if I had the same problem. But I had disc problems, getting pain, spasms, some nerve irritation. It works great for that. Now, getting repeated injections to your knee for arthritis, over time you can do some damage to it. And if you have too many steroid injections or take steroids systemically, then you can get other side effects. The one we see is, in addition to osteoporosis or softening of the bones, more common in women, is we see something called avascular necrosis, which is loss of blood supply to the ball part of the hip joint more commonly.
What did you call it?
Avascular necrosis. It's got a bunch of other names as well, but it just means that the ball portion of the ball and socket loses its blood supply and then it collapses, and you need a joint replacement after that. So we're careful with steroid
So you want to
use.
do aerobics? Does that keep your blood supply up? So you need to do
Then what
cardio all
different-
the time?
It certainly has its benefits, but it won't help your hips as far as blood supply. They're unrelated.
Where does blood supply come from? Where does that?
So we all have small arteries and arterioles that go to the bone. And for some reason, when you take steroids, drink alcohol, get the bends, there's actually 60-something causes of this process. There's something pathologically that happens that increases the pressure in the hip joint that the blood can get there, but it can't get out. And it gets a kind of a clogged situation. And so you end up with this problem. Fortunately, it doesn't happen very often, except for patients who have exposure to these things on high doses.
Like alcohol and steroid shots?
Right.
Uh-oh. So you're an author. You lecture. You said a little bit you're going to go lecture about, well, I'm going to tell everybody that just tuned in that you're listening to Up in Your Business with me, Kerry McCoy, and I'm speaking today with Dr. Lowry Barnes, an orthopedic surgeon in Little Rock, Arkansas, who is internationally known for his patents and innovative approach to hip and knee replacement surgery. If you missed the first part of the show, you should go listen to the podcast next week, because everybody's got arthritis, everybody's got questions, if you live long enough, you're going to have a few aches and pains. And he says, you say, no pain pills.
No narcotic pain pills.
Over-the-counter pain pills work great.
You bet.
They really do. And if you get immune to one, just switch to another one.
Absolutely.
Don't you think?
No doubt about it.
So you're an author. What do you write about?
Hip and knee replacements.
Oh,
so
yeah.
we publish articles on our research, on our patient series, and how patients do with certain procedures. And that's what our department does. It's not just me. We certainly have a group of 4 hip and knee surgeons who do this together, but we have 26 orthopedic surgeons in the department who are working in different areas, and we're all looking at what we do and how we do it and what we can do to move the field forward. That's
so now that you're an academic, you said earlier that you've been out of private practice for about 4 years, I think you said.
Something like that. Mm-hmm.
Now that you're an academic, I guess you lecture all the time.
Well, I lecture probably the same amount as I always did, because most of my lecturing is nationally, internationally for meetings. That the medical school, there's not a whole lot of orthopedic lecturing during the medical school years. They learn from rotating with us. So going to our clinic, going to the operating room with us, and learning that way.
Mm-hmm.
But we teach residents as well over a 5-year period.
What do you want your legacy to be?
Great question. Hopefully, right now, I'd say it's I'm in a second career. I still may want to have a third career. We'll see.
I agree.
I think change is good.
I agree.
But right now, my legacy is to make orthopedics better in our state and improve the health of Arkansas through UAMS and what we can do to make the state better.
Don't you wish wisdom was transferable?
No doubt about it. I wish that somebody had transferred some to me.
You wouldn't listen.
Good point.
That's the problem.
That's right.
But at least people are paying money to come hear you talk, so maybe they're going to listen to what you have to say. I want to thank you so much for coming on. I have a gift for you.
Well, thank you. I love it.
It's a U.S. and an Arkansas desk set. You can put it in your office, your teaching office up there. We're lucky to have UAMS. We had Hank Kelly on last week, who said that one of the things that makes a great city is a research college.
He is correct.
Because it brings in talent and it brings in patients who find out about the city of Little Rock and often are surprised at how nice it is.
It's a great place.
It's a great place to live. Any advice you'd give yourself from 20 years ago?
Listen more, talk less.
I just learned how to do that.
Congratulations. I'm still trying.
No, you're a great listener. Gray, who's our guest next week?
Next week is a special SOMA show with a few different entrepreneurs from South Maine. So Anita Davis of the Essie Purse Museum and a few other folks.
I think we're going to have, who's the ice cream shop?
I can't remember her name, but she's
Sally.
Sally of Loblolly Ice Cream, and Jack of
Root Cafe.
The Root Cafe, and I think some other people, including maybe Hank Kelly, actually. So.
Because they all talk about Soma. They all talk about South on Main and how it's changed and how it's grown.
How important it is.
And so people that are listening from far away, we're talking about South and Main and Little Rock, Arkansas, and a resurgence to our downtown area. It's really been great.
Come visit.
I know. There you go. Thanks again so much. I really enjoyed visiting with you and meeting you. You're a special guy.
You're kind. Thank you. I've enjoyed it.
You're welcome. For those of listeners who might have a great entrepreneurial story that they'd like to share, I would love to hear from you. And you can send me a brief bio. You can send your contact info to Kerry at flagandbanner.com, and somebody will be in touch. Son Gray might answer you back. We are booked all the way through December with guests, and we're talking about going up to Fayetteville and interviewing some people in Fayetteville in 2020, which I can't believe is right around the corner. And we'll get some, there's a lot of interesting people up in Fayetteville that I really enjoy going up there. And it's odd. Not that many of those people come to Little Rock very often. It's kind of like people in North Little Rock don't come to, it's kind of like people in Little Rock don't go to North Little Rock very much.
It's like a whole different state.
It's kind of funny. Little Rock people go to Fayetteville, but I don't think Fayetteville people come to Little Rock. I think they go to Tulsa or somewhere like that. But anyway, if you've got a great entrepreneurial story that you'd like to share, if you're anywhere in the state, send me your brief bio and your contact info, and someone will be in touch. And to all, thank you for spending time with us. We hope you've heard or learned something that's been inspiring or enlightening. And if you haven't, then you haven't been listening. And that whatever it is, will help you up your business, your independence, or your life. I'm Kerry McCoy, and I'll see you next time on Up in Your Business. Until then, be brave and keep it up.
You've been listening to Up in Your Business with Kerry McCoy. For links to resources you heard discussed on today's show, go to flagandbanner.com, select radio, and choose today's guest. All interviews are recorded and posted the following week. Subscribe to podcasts wherever you like to listen. Kerry's goal is simple: to help you live the American dream.